Today we're going to finish talking about hypersensitivity and then talk about some different therapies that are used for allergy as well as for autoimmunity. And you'll see kind of this overall immunotherapy theme, which is going to spill over into some other things that we talk about later on as well. Remember, you have assignments due next week on Monday, so make sure you're taking a look at that on Moodle if you need to do so. We started talking about hypersensitivity reactions on Monday. And if you remember, hypersensitivity is the fancy immunologist word for allergy, and it's specifically defined as making an immune response to something that is sort of foreign but innocuous, unlike autoimmune disease that is making a response to something that is self. In either case, as I mentioned on Monday, we're kind of thinking of examples of too much immunity compared to some other things where we're thinking about too little. There are 4 big types of hypersensitivity reactions. Very creatively named types 1, 2, 3, and 4. And we talked through types 1 and 2 last time. If you remember, type 1 is mediated by IgE and mast cells and leads to mast cell degranulation, while type 2 is mediated by antibodies of either the IgG or IgM isotype. And the thing that was particularly important to remember with type 2 is that the antigen is on the surface of a cell. And the thing that happens as a result of the IgG or IgM in this case is that this cell that has antigen on its surface gets killed, potentially by NK cells, potentially by complement. There are lots of different things that can happen to the cell, but the point is we lose the cell. Today we're going to talk about types 3 and 4 to sort of start out with. And so we're going to move into thinking about a type 3 hypersensitivity reaction. And I mentioned to you last time that I remember learning the hypersensitivity reactions the first time and being a little confused when I looked at type 2 versus type 3 because the textbook that I was using at that time said basically IgG or IgM for both type 2 and type 3, and I was like, but then what's the difference if they both involve IgG and IgM? And in fact, they do both involve IgG and IgM. The thing that is different with the type 3 hypersensitivity reaction is that we have soluble antigen. So it's not an antigen that's on the surface of a cell. It's like a secreted protein, or it could be not a protein, but you can imagine some kind of extracellular floating around molecule. And as a result, we end up seeing immune complexes get formed. And so type 3 hypersensitivity reactions are also known as immune complex reactions. Or, as you can see here, immune complex disease. So with a type 3 hypersensitivity reaction, we're seeing some kind of higher order structure with multiple antibodies binding to multiple antigens in sort of a big cluster like this. And these free immune complexes are actually what is causing the problems with the type 3 hypersensitivity reaction. If you remember when we were talking about different types of autoimmune diseases, we saw some immune complex mediated autoimmune diseases. So you've seen a little bit of issues with autoimmune disease and immune complexes. And in fact, if you look back at some of those autoimmune diseases, there are some that basically look like a type 2 hypersensitivity, some that look like this type 3, some that are going to look like type 4. So it is very similar to things we've seen before. I want to mention a couple of sort of big picture things about immune complexes on the next slide, and sort of how immune complexes can cause damage. And then I'm going to tell you about sort of the most famous example of immune complex mediated hypersensitivity reaction that people could have. And to be perfectly honest with you, as I'm looking at these slides now, I was looking at these, thinking about this the other day when we were talking about immune complexes and autoimmune disease. And part of me was like, why didn't I have this like explaining immune complex stuff then? That would have been a good idea. Remember that for next year, self. The idea with immune complex formation is that we remember that our antibodies each have 2 identical binding sites for antigens, and that an antigen may have kind of multiple copies of the same epitope. If it works out that we have sort of just the right concentration of antigen and antibodies, we can start to make these huge structures where multiple antibody molecules are binding to multiple antigens. Each antigen is bound to multiple antibodies, and you get this really big structure. You can see that, if there's too much antigen, then you don't really get immune complex formation. If there's too much antibody, then you don't really get immune complex formation. But it's sort of, again, you have to have just the right concentrations of the 2 of them. One of the things that's important, and you'll see this graph that I have at the bottom again in a little bit, is that you should remember that typically the amount of antigen doesn't stay the same during some kind of infection. Eventually you're going to get rid of it. And also the amount of antibody doesn't stay the same. Antibody sort of increases at a certain rate. And so usually with immune complex disease, we only see a problem at sort of like this middle time period where kind of if the concentrations happen to cross each other at just the right spot, then you can see immune complex formation. And those immune complexes can cause disease in a few different ways. So here you can see some immune complexes that have been formed. Again, you can see our little flower antigen. It's not on the surface of a cell, it's just free floating around. Binds to antibodies. You can see each antigen has multiple antibodies bound. Each antibody has multiple antigens. We get an immune complex. And at this point, we can start to see things like potentially some inflammation due to mast cell or other cell degranulation at that site. But we can also see all of the different aspects of inflammation that we might think about, like changes in the blood vessel diameter and leakiness of the blood vessel. And so we're going to see increased fluid and protein release. We're going to be bringing in phagocytic cells, and we're just going to start a general inflammatory response. We're also probably going to block this blood vessel. This isn't entirely to scale, but we'll go with it. You can imagine if this thing went into this blood vessel, that blood vessel would be blocked, if we think about the sizes. So we can also imagine blood vessel occlusion. You can see this here as well. Sometimes those antigen-antibody complexes might even get stuck on the wall of the blood vessel. And then we're going to start having inflammation at the blood vessel. We're going to start having things like FC receptors on different cells are going to come in and be like, oh, I should inflame this. There's a whole bunch of FC receptors, or FCs here. So we're going to start to get destruction of the blood vessel. If this got stuck and deposited in the glomeruli in the kidney, that are really small, delicate places where we're doing filtration, then suddenly we're going to inflame the kidney. If this got stuck in the alveoli, we'd suddenly get inflammation of the alveoli. We're probably going to induce some clotting and potentially some complement deposition here with all of this. And so you can see that this could lead to a number of different types of disease. There's, just like with some of the others, you remember with the type 2 hypersensitivity, I gave you kind of like the classic example that every immunologist thinks of when they think of that type thing. Or when we talked about immune privilege, I was like, the example every immunologist knows is sympathetic ophthalmia. Like there's the one example everybody knows. There's a one example that everybody knows for a type 3 hypersensitivity reaction to. It happens in a particular situation that I have to tell you a little bit about. I actually told you about this situation earlier in the semester, but I want to remind you a little bit about this situation, and then we can see how it may lead us to a type 3 hypersensitivity reaction. So the situation where we sometimes will see a type 3 hypersensitivity reaction happens when patients may get something called passive antibody therapy. So passive antibody therapy is so named because what we can do is we can take some antibodies from an immune individual and inject them into a person who may be infected or may be at risk of infection, and that will allow the antibodies to destroy the microbe and the person to recover. But this person won't have to wait for their B cells to get primed and go through all the steps of making an adaptive immune response. They'll have antibodies in their bloodstream immediately. Of course, they also won't have their B cells get primed. And so if they had this same infection again, we'd have to give them antibodies again. They wouldn't have a memory response. They'd be making a naive response again. So their immune system didn't do anything. That's why this is passive immunity. Sometimes people contrast that with giving a vaccine, which is active immunity, where your immune system does something, but we'll say more about that when we talk about vaccines. And so this can be particularly important if we're trying to help someone deal with something that is very severe and needs a really quick response, where you don't want to wait to make your own response. It also is used in a number of situations where we might have a new infectious disease where we don't yet really have any other treatments. Sometimes taking antibodies from the blood of survivors can help. So in fact, early in the COVID pandemic, you may have heard of some use of something called convalescent serum. That's this. And there are a bunch of other situations like this. But some of the places where this is used pretty frequently are shown on the right here. And I'm going to point out things like the black widow spider bite. It's true of botulism, it's true of rabies, it's also true of snake bite. I'm kind of going to highlight those. All of those things are things that if you either have that infection or have that situation, are going to lead to some kind of venom or toxin causing you damage real fast, like within hours to days. You might die within a day. And so if you do not, you don't have time to wait around for clonal expansion of the B cell and the T cell to give help to the B cell, the germinal center reaction to make, you don't have time for that. You need antibodies now. And so we're going to inject antibodies into you. And so in fact, if you were to have a black widow spider bite, you would be given antibodies against that venom to neutralize that venom right away. But we can think about, and I've kind of already mentioned this, what's going to happen. So let's imagine you have a black widow spider bite. You get treated with passive antibody therapy. What happens if you are bitten by a black widow spider again, and you get a second black widow spider bite in your life, other than us asking some questions about your life choices? What is going to go on in terms of immune responses and you and that black widow spider bite? Yeah, Emma.
You're going to need more antibodies because your body's not going to be creating the initial immune response to the venom.
Yeah, you never actually primed any B cells. You never did that germinal center reaction, did all that stuff. So if you get a black widow spider bite a second time, you're going to need to get this passive antibody therapy again. The type 3 hypersensitivity reaction that I'm mentioning here is sometimes a complication that can happen when you get passive antibody therapy. So passive antibody therapy is great. It's going to like save you from dying from your black widow spider bite. But sometimes you can have this complication. It can happen the first time you get it, but the most severe and the most obvious examples that we might think about are going to be if you, for example, got that, it's the second time. So you got that second black widow spider bite in your life. Again, we're going to ask other questions about your literature. That's okay. So let's look at this table for a second and think about what it says. What does this table say that you are going to be treated with for your black widow spider bite? Yeah, go for it, Alexis.
Horse antivenom.
Horse antivenom. So what does that mean? Yeah.
They're antibodies from a horse.
It means antibodies from a horse. So here we see, antibodies from immune individual. The immune individual was a horse, right? It's a really hard question. You ready? Are you a horse? No, right? Antibodies are proteins. So basically what you're doing to this person who has a black widow spider bite is you're injecting them full of horse protein, a foreign protein from horses. You are injecting them full of antibodies that were made in horses. And so they are technically foreign proteins that you were injecting this person with. So what do you think might happen in our poor black widow spider bite victim when they get this treatment with horse antivenom? Yeah, Vicki.
The body might start like attacking the person.
Yeah, you are going to start making an immune response to horse antibodies. You somewhere have a B cell that can respond to like the FC portion of a horse antibody, which is different than the FC portion of a human antibody. Not like exactly the same amino acids. I have no idea which ones are different, but I'm sure there are some. And so you're going to start priming that immune response. Now, if you have your black widow spider bite and then have just that one and go about the rest of your life, do you care that you made antibodies against horse antibodies? No, you are probably, horse antibodies are not things you are likely going to have in your body very often. The fact that you've got a whole bunch of antibodies against them, no big deal. What happens if you have to get this treatment again for a black widow spider bite? Or what happens if you have to now get this treatment for a snake bite? Yeah?
Your body's going to reject the antibody.
It's not, we can argue about using rejection, but your body's going to respond to those, and you are actually going to make basically a sort of a memory antibody response to the horse antibodies that you're putting in. And what you're going to end up having happen is you're going to get immune complexes. In this case, the antigen is the horse antibody, and the antibody is your antibody, but it's going to make these immune complexes. This is known as serum sickness. We used to think about passive antibody therapy as treating you with serum, and so sometimes you could get sick from serum. And usually the idea is, this yellow line you can imagine is the horse antibody. You inject it into you. You're going to have a lot of it. Eventually it's going to degrade. And over time, you are going to make your own response against horse antibodies, which is in red. And at some point, they may cross at a point where you actually can get these immune complexes formed and can start to get things like fever, vasculitis, arthritis, nephritis, inflammation of a number of different locations because of this. And you can imagine that a second treatment with that same antibody from a horse is going to be, make you even more likely to have this happen, and is going to be even more severe. So typically, we can actually have slightly different things happening with serum sickness, particularly as we're doing an intravenous inoculation of the antigen, where we'll start to see disease of the blood vessel walls, glomeruli, and joint spaces. Sometimes if those immune complexes deposit in the skin, you can get reactions that look like the reactions that are shown here. We can also sometimes get reactions where those immune complexes are starting to deposit in the lung. And so this is all sort of the major example for type 3 hypersensitivity. And I didn't totally plan this way, but this is also going to be a nice segue to something I'm going to tell you about later on in today's class. So at this point, we've talked about types 1, 2, and 3. We also need to talk a little bit about type 4 hypersensitivity. If you remember back to type 1 hypersensitivity, when I was telling you about type 1 hypersensitivity, one of the things I told you is that it's known as immediate type hypersensitivity. Because with a type 1, you tend to see a reaction in sort of that 10 to 15 minute range after seeing the antigen. Asterisk. What's my asterisk there? 10 to 15 minutes after seeing the antigen. What is it? The second time. Remember, you have to first prime the response. So the first time you don't have any issues, because you have to have the T cells become Th2 cells and have the B cells switch to IgE. But the second time around, now you're ready. 10 to 15 minutes later, bang. With type 4 hypersensitivity, there's a little bit of a difference in timing as well. So this one also has kind of a characteristic timing. And that characteristic timing is not 10 to 15 minutes. Instead, it's usually about 72-ish hours, sort of maybe 48 to 72 hours. I think I've heard 24 before. But whenever I have a bunch of these reactions in different situations, in my mind, it's a good 2 days, sort of 48, 72 hours. And again, it is 48 to 72 hours after the second time. And so, just like you saw with that type 1 hypersensitivity, you do need to sensitize the response and sort of prime the response and push it in the direction of the adaptive response that we're going to see before we see this response. You can also notice that on the right, you can see some of the antigens that are associated with type 4 hypersensitivity responses. So there are a number of different microbes here, but the ones that I think most people think about when they think about type 4 hypersensitivity are, well, I'm going to mention some things about Mycobacterium tuberculosis, so we'll come to that. But also things like a poison ivy or poison oak reaction, or if you have a reaction to, say, nickel. If any of you wear sort of cheap costume jewelry and you wear it a while and the covering rubs off and then you start getting a really bad reaction, that's a nickel type 4 hypersensitivity. And so it's all kind of the same reaction in here. Your textbook is showing it happening with a nickel piece of jewelry and the nickel in the skin. And usually we think about these as being particularly important when you're sort of making contact with the antigen. So oftentimes we think about these with being pretty skin-oriented. So one big difference that you should sort of note about the type 4 hypersensitivity reaction is that timing, the delayed type hypersensitivity. In fact, sometimes in the literature these are known as DTH responses, which stands for delayed type hypersensitivity. The other thing that's unique about these is that all of the others, type 1, 2, and 3, the problem was an antibody. In type 4 hypersensitivity, the problem is a T cell. And so this is mediated by T cells as opposed to being mediated by antibodies like all the other ones. And so the first time you see the antigen, you will have that sensitization phase. So again, this is the first time I wear the cheap nickel jewelry that I basically had to stop wearing thanks to these sorts of things. So the first time, the antigen, here it's saying intracellular bacteria, but in my case it would be nickel from the jewelry, is going to get presented, and we're going to, by some APC, and we're going to push a T cell to be a Th1 cell. And we're going to start making a Th1 response with interferon gamma and all that good stuff. And then the second time you see the antigen comes around, oh my gosh, you already have a Th1 cell ready to go. No more naive cells. And so now that Th1 cell can start making cytokines, we can start activating macrophages, and we can start having all of our effects. And that might look like something like this. So here's our antigen, goes into the antigen-presenting cell. A Th1 cell, which was made the first time you saw that antigen, the first time I wore the cheap jewelry, now comes to this location and starts to induce a whole lot of inflammation in my skin. And that will lead to changes of the blood vessel, that'll lead to phagocytes coming in, and all of the things that you can imagine happening with sort of that kind of skin inflammation. Honestly, when I think about a DTH response or a type 4 hypersensitivity response, sometimes I kind of think of it as just being like a fancy word for a Th1 response. Because it's just a Th1 response that's happening against, something that's harmless instead of some kind of microorganism. So I have 2 different examples of a DTH response that I want to tell you about. Though you can see lots of examples here. And here you can also see, here's my cheap jewelry. It goes, we activate some T cells, then later on when I wear the jewelry, the T cells are going to come back. This also will help you remember things about what's going on with that delayed type response, that say 48-ish hours. Why does it take 48 hours? Well, because we have to actually have antigen get to the lymph node. And we have to have that T cell that was previously activated get back to the site and start causing damage. So this isn't, there does have to be trafficking. There has to be transcription. There has to be translation. In the case of the type 1 hypersensitivity, the mast cell already lived wherever. You have mast cells in all sorts of tissues, so we didn't have to traffic. And the mast cell already had made the granule stuff, so we didn't have to transcribe or translate anything. The mast cell just had to release things, whereas here we need to move the T cell around. The T cell actually has to do some responding, so that's where that 48 to 72 hours is coming from, unlike the other responses. Did you have a question, Josh?
Yeah, so poison ivy,
yeah.
So let's just say, for example, if we just didn't have like a poison ivy antigen, we wouldn't be affected by poison ivy. So it would just be...
So, Josh wants to know about poison ivy, and one of my 2 examples is the poison ivy example. So poison ivy contains this compound, erysiol, which is shown here. When you are exposed to erysiol, it actually modifies a self-protein. And so it reacts with a self-protein and changes that self-protein. So now that self-protein looks like a foreign protein, where it didn't before. And so, again, the first time, you really don't have much of a response. Maybe a little bit later if it's sort of persisting. You'll get to the point where those T cells can get there. But you will sensitize Th1 cells. And then the second time and later times you see poison ivy, you will already have Th1 cells ready to go. They will be able to go back to that site. They will start to cause inflammation at the site. They'll cause fluid leakage into the skin, all of that stuff that can give you the blisters that you associate with poison ivy. So does that answer your question?
Yeah.
Okay, awesome. So this is sort of one of the types of response that is sort of classic for a type 4 hypersensitivity response. The other one is one that I could tell you so many fun facts about. I could just like go off on, but I'm going to hold myself back a little bit. But it is related to tuberculosis and the infectious disease of tuberculosis. So I've got to tell you a couple little things about tuberculosis right now. So tuberculosis is caused by a bacteria called Mycobacterium tuberculosis. And sometimes it can sort of, lead to coughing and all of these things, and you'll breathe out Mycobacterium tuberculosis and infect other people, and that's bad. In other times, it will actually live in your lungs without symptoms, asymptomatically. So you can have what's known as latent tuberculosis living in your lungs. And at some point, that latent tuberculosis can come back. Can actually, basically, with latent tuberculosis, your immune system is sort of keeping the bacteria in check. And at some point, the bacteria can kind of break free. It might be because you're stressed. It might be because it's a Tuesday. Like, it can be for lots of reasons. And the reason why this is important to know is that it can be really important for us to know who has those latent tuberculosis infections. Because we want to know if somebody has those latent tuberculosis infections, because we might want to treat them, or we might want to think differently about, how we have them around others in the population. This is especially important, say, if you were going to be a healthcare worker. So if any of you guys have worked in any kind of hospital setting or volunteered or anything, you have had to have tuberculosis testing. And really what they're doing is they're checking to see if you have latent tuberculosis. Because they want to know, before you're around a whole bunch of patients, if you happen to have this microbe chilling in your lungs, that you could potentially be a risk later on. Make sense? So how could you find out if you had this bacteria latently growing in your lungs? What would be kind of the most obvious thing you could imagine doing? I'll tell you, it even grows in a special kind of mass in your lungs. Yeah, Josh?
I guess you can do like an analysis of like your I don't know, like if you I have an idea in my head. I don't know if it's possible.
Okay.
But in my head, it's just like if you can maybe look at you want to look at your gut your gut ecosystem to see
Okay.
which bacteria is there.
Okay, so we're really thinking about lungs here,
Oh.
less so than gut. How can I see right now? I wanted to know right now if you had that bacteria in your lungs and it grows in this like unique kind of mass. How would I know? Yeah, Ashley.
Could you do an X-ray?
I could do an X-ray of your lungs, right? And it does. It shows up really obviously on a chest X-ray. So, okay. Chest X-rays are kind of expensive. And they're also kind of like, a little bit of risk having the X-ray, right? It's one thing to like have a chest X-ray at some point in your life. It's another thing to like, I don't know, have a chest X-ray once a month. That's like not a great way of thinking about medical care. And so fortunately, we have another way that we can test to see if you have tuberculosis. And basically what we're doing here with this test is we're looking to see, do you have T cells that have been sensitized? to tuberculosis. If you don't have this bacteria in your lungs, then your T cells are naive, right? And so you can't make a DTH response because you didn't have the first step. But if you do have this bacteria in your lungs, secretly hiding, you've got some T cells that should be primed and recognize it. And if we try to give you some antigens, you're going to make a DTH response. And so that's actually how we test for tuberculosis. It's known as the PPD test, or the purified protein derivative test. If you guys ever think about having gone somewhere and having to have, quote unquote, a TB shot, you were having a TB test. You weren't actually, it was not a vaccine. There is a TB vaccine. It's not used in the United States. It's only used in some other countries. And the short answer to how I feel about it is that it sucks. There are a lot of issues with that vaccine. But what we can do is we basically just take purified antigen from a mycobacteria, from a bacteria in this class, and we inject a little bit under the skin. If all T cells are naive, you're not going to have a DTH response in 48 to 72 hours. If, however, you already had Th1 cells, you are going to have a reaction to this. And in fact, we measure things like how red, how raised, and you get a very characteristic response to this. And so, when I have to go to a TB test, one of the things I'll do is I'll just rub my arm like this to check it, because if your arm's flat and there's not a bump, that usually tells you it's a negative. And so you wait, you basically deposit some antigen, wait 48 to 72 hours, and then look to see, do you have a DTH mark or not? And so this is the other really famous way that we can that we think about DTH responses. Again, holding myself back here. I might say more about this depending on timing next week. Like I said, there's a lot of not great things about the tuberculosis vaccine. And one of the reasons why we don't use the tuberculosis vaccine in the United States is because it's got a lot of bad cons to it. And if you had the tuberculosis vaccine, then you test positive with this test. And so our quick, easy, cheap test wouldn't be useful anymore. And so we're kind of like, yeah, we don't want to give everyone chest x-rays all the time. So we're not going to give them the sucky vaccine. We're just going to make it so our test still works. And so some people, for example, if you were born in some countries outside of the United States, you may always test positive on this, and it may be because you were given the tuberculosis vaccine shortly after birth. And so if you are that one of those individuals, like, you probably know about it, and you end up having to get chest x-rays every time instead of getting PPDs. I will also caution any of you who happen to be going into medicine or sort of the biomedical field, if particularly you're super fair skin, and you have to get a lot of PPD tests, you can develop a different type of hypersensitivity response to this antigen. You can actually become allergic to it in a different way. And if you are, say, an immunologist, you can then argue with the nurse a whole bunch, and be like, no, that's not actually what a type 4 looks like. That's really a type 1, and like, let me show you all the reasons. They don't like that very much, but... So, and again, I could go on and on about that for a while. I will tell you, if that does happen to you, you can argue that it's not really the right response. You just have to really work on the argument. There's actually a different way they could do the test that will not make you positive. They don't like it when you suggest that either. And also, if you actually then stop getting PPDs for a while, the response, you will stop having that response. Not that I know any of this from personal experience. So one other thing that I just want to mention, kind of because there's not like a great other place to put it, is that with all of the things we've been talking about, the types of hypersensitivity responses and the autoimmune responses before that, we're basically thinking about kind of too much immune system. And there are another group of syndromes that I think could be classified as too much immune system, but they sort of don't fit into either of these categories of hypersensitivity or autoimmunity super well. And those are diseases that involve chronic inflammation. And so the idea here is it's kind of like too much innate immune system instead of too much adaptive immune system. Because with autoimmunity, we specify it's a self-antigen. With hypersensitivity, we specify it's an innocuous antigen. If it was an innate immune response, then there's kind of not really a specific antigen that we might be thinking about. But we might have too much inflammation going on for a number of reasons. And we are finding more and more diseases where chronic inflammation is the sole cause or a contributor. And so exactly where chronic inflammation and chronic inflammatory disease fits into this is a little hard to say, but I will also just point out that this does exist. And there are some diseases that I really swear every immunology textbook I have puts them in a different chapter, because you're arguing, well, is it like even with poison ivy, it's a foreign poison ivy thing that modifies a self protein. So is that an anti-self response or an anti-foreign, like anti-innocuous response? And like you can start to, with some of them, and like how much of it's inflammation and how much of it's foreign and how much of it's self, some of them can get really messy, and so sometimes like exactly having dividing lines between these things can be difficult. And so some of the diseases that you may see listed in different places as autoimmune diseases or hypersensitivity diseases maybe are neither and are instead chronic inflammation. It's hard to make that distinction, so I just wanted to point that out. But for the rest of the time today, and this is really kind of getting towards that other idea, this sort of idea, we have been thinking about all these diseases that are on the too much immunology side, the too much immunity side. I'm going to spend the rest of the time today talking about some ways that we treat either first allergies or autoimmune diseases. And so how we kind of take this too much immunity and we move it back down into the sort of good range. There are lots of answers, and all of the different answers sort of tie into other things that we've thought about this semester. And so first, to think about allergies, we've got a lot of different ways that we can treat allergies. And really, when I'm talking about allergies here, to be honest, I'm really especially talking about type 1 hypersensitivities for a lot of this. And the key thing that I will mention with sort of this and the next few slides, where I'm kind of focusing on type 1 hypersensitivity and allergy treatments, is that if you think back to that slide I showed you with the compare and contrast with autoimmunity and with transplantation and with hypersensitivity, type 1 hypersensitivity was like unique. There isn't an autoimmune disease that acts like a type 1 hypersensitivity. When we do transplant rejection on Friday, there's not a type of transplant rejection that acts like this. And so because this acts a little bit differently, the way we treat it is kind of a bit unique, whereas the other ones tend to be kind of more of the same thing over and over again. So you can see there are a whole bunch of different things one can do to treat allergies. Some are listed here as being sort of more in clinical use. Some are things that are proposed or under investigation. One of the big things that we can do to treat allergies is we can actually just try to block some of the mediators that the mast cells make. So we know in this type 1 hypersensitivity reaction, mast cells are the problem child. So what we do is we actually block some chemical that a mast cell makes. And so you can see this here. The most famous are the histamines. And so you can use an antihistamine and block histamines. And then, so basically, you're still letting the mast cell respond, you still have the IgE, you're still responding to the antigen. This mast cell is still releasing stuff. You just have a chemical or some sort of chemical way to stop the histamine from working. Yay. A little sad because some of these other things might still be happening with the cytokines and some of this other stuff, but you stopped, the immediate symptoms. Sometimes when I talk about some of this stuff, I pull up some commercials for some of these drugs, and I don't have my commercials pulled up, so I'm just gonna have to mention them. I might, depending on timing, I might pull up one in a second for one of the other drugs. But one of the things you can find is you could look for a commercial for an allergy medicine called Flonase. And some of the early Flonase medicine commercials all talked about block 6 key mediators, and 6 is greater than 1. They all talked a lot about how 6 is greater than 1. And if you look at, 6 is greater than 1. If you read the package, it tells you what the 6 are. Do you want to know what the 6 are? Histamine, prostaglandin, cytokine, this is what the 6 that they go on and on about are just the exact 6 things that are being shown here. And so sometimes you might block multiple mediators, sometimes you might block one. That's all that's going on with a bunch of those different meds. One thing that people have thought about is actually trying to do something to block the IgE. Let's see if we can go a little further up in the process. Not just block the 1 product or 6 products that come out of the mast cell, but stop the mast cell from getting IgE on it in the first place. So we could block IgE binding to the mast cell. And you can see this type of thing. And so there's this idea, perhaps if we were to treat people with antibodies against IgE, that would bind up all the IgE and keep it away from the mast cells. And so we wouldn't then have the mast cells ready to go because the IgE would not have been bound. One of the sort of other sets of things that we tend to use will be things like epinephrine, aka an EpiPen. Note that basically what's happening with epinephrine is that we are binding to some receptors on mast cells and stopping mast cells from being activated. So it's not up as far as keep the IgE off the mast cells, but it is at least stopping the mast cells from making all 6 products instead of blocking just 1. So that can be cool. So it's really acting by stopping signal transduction in the mast cells. We can also use different kinds of corticosteroids. And those corticosteroids also are impacting signaling on mast cells, as well as a whole lot of other cell types. And so those steroids are going to really kind of generally inhibit a lot of immune responses. And so you can see this includes things like prednisone, hydrocortisone. All of those things have these sort of similar structures. They bind to a receptor in the cell and change gene expression in those cells really broadly. And since they can go through the cell membrane, they're not real picky about what cells they hit. They kind of hit all the cells and impact transcription in all the cells. And so in general, you can see that when we treat with those corticosteroids, we are decreasing a whole bunch of cytokines, we're decreasing a whole bunch of lipid mediators, we're decreasing adhesion. This doesn't show impacts on lymphocytes as much, but it totally impacts lymphocytes. It just kind of depresses the whole immune system pretty broadly. Which, again, if you are having some kind of ongoing allergic reaction, might be really useful for you. We also see it's a little sad because it's not super specific. You might be worried about infections. One other thing that I want to just mention about this is that you can look at this slide and you can see the similarity between prednisone and hydrocortisone. We also have a similar molecule, cortisol. Have you ever heard of or thought about cortisol before? What's cortisol? Yeah.
It's released when you have high stress.
Yeah, it's a big stress hormone. So just based on this, what do you think happens when you're feeling really stressed and you start making a lot of cortisol? Like, I don't know, at the end of the semester, getting close to exam time. What generally might start happening? What do you think, Andrew?
So the release of cortisol, they make more, or like similarity.
Well, so they basically make a molecule that looks really similar to these. And so then what's going to happen to you? Your immune system is going to be getting suppressed somewhat because you're making versions of these molecules. And so, people want to get into the details of what goes on with the immune system and stress. And as far as we know, it's really just cortisol doing the same thing that like a prednisone or something would do. It's just sort of very broadly impacting a whole lot of cell types. Yep.
Simple question.
Yeah.
I feel like kind of a hallmark of like steroid treatment is like your body swells.
Your
body like tends to swell. Like I feel like sometimes there's a lot of like water retention.
Mhm.
Is that because of the decrease in vascular permeability by the decrease in inflammation?
I'm not 100% sure.
Mm-hmm.
I think some of it may have to do with kind of other metabolic sort of kidney types of things, and I'm not positive.
Got it.
So there's one other thing I want to mention in terms of treating allergies and the way people think about allergy treatments. And I have a much better slide for this, and why I don't have it, I don't know, but that's okay. But if you remember, I told you about this idea that where you first encounter allergens can impact what kind of response you make. And specifically, I told you that encountering some kind of antigens through the GI tract tends to push you in a more tolerogenic environment. And so there is this idea that if we start to feed people some of their allergens, you have oral immunotherapy, then you may actually start to lead to more regulatory T cells and actually may reduce the response. And so this idea of oral tolerance therapy is something that people have thought about for sort of pushing some, or sort of reducing some allergy symptoms. Sometimes this will even happen, sometimes there will also be cases where we will inject sort of very small amounts of allergen for patients and sort of keep increasing the amount with the idea of basically trying to exhaust the T cells and trying to desensitize the cells. In particular, some of the oral tolerance stuff has done some really cool stuff for, say, people who have such severe peanut allergy that like they would die if you opened a bag of peanut M&Ms in this room. Like that, like the smell of just that much would kill them. Like we can reduce their level of allergy to the point where like they could be in the normal world. But they're not gonna ever like chow down on some peanut butter. So we can sort of reduce in some cases, and there are some cases where we will see that sensitization therapy work well for certain allergens. There are certain cases where we do see oral tolerance working pretty well. It's not super well understood or super well worked out, but this is another sort of idea and situation that's used in some cases. Do you have a question, Josh? Or?
Oh no, because I've always heard that when people eat honey, right? So honey helps you all.
I hear that a lot about local honey. It has to be honey from your exact local environment, so it has this right exact pollen from the bees. I've heard that as well. Maybe my honey isn't local enough. It hasn't at least had much of an effect for me, but I've heard the same thing. And when I've when people have tried to be like, this is a thing, I've been like, well, I could imagine a mechanism. Like, you want to eat some honey, eat some honey. So yeah, I've heard the same thing. It hasn't always done a ton for me, but we can also think about some other kinds of treatments. Some of these this is listed as sort of treating autoimmunity. Sometimes some of these treatments that we see are going to be treatments for transplantation as well, which we're not doing until Friday, but oh my gosh, we're going to be seeing some similar treatments. Some of them will even work for particular types of hypersensitivity responses that have similar mechanisms to autoimmune diseases. So that's kind of why I'm putting them all together. I've already told you about one of these treatments, so I'm not going to spend a ton of time mentioning it. Just I'm going to remind you that one big treatment that can be used is cyclosporin A. Remember that cyclosporin A will block NFAT activation, so that NFAT is no longer able to go into the nucleus and lead to transcription and T cell activation. Good news about NFAT: you don't get the T cell activation, you stop the pathologic response in the patient. Bad news, you broadly immunosuppress your patient. And so kind of your whole all the T cells in the whole body are kind of depressed down. So now your patient is going to have some risks. Other thing I will point out really briefly about cyclosporin A. Let's imagine I think about my pollen allergy, which, as we know, is really the only reason to think about allergy, is just my pollen allergy. My pollen allergy, which is definitely a type 1 hypersensitivity. In May, when I'm suffering, do you think I should take some cyclosporin A? So why do you guys say no?
Well, I would say the negatives still outweigh the positives.
Okay.
If you be immunosuppressed during that time that you take that.
Okay. All right. So I agree, but there's one piece we got to pull out of that. But I totally agree with you. Yeah.
I mean, if it's a type 1 reaction, it's utilizing antibodies, so it wouldn't be using T cells.
Yeah. This works for responses that are T cell mediated. So in fact, as Andrew points out, the risks outweigh the benefits. Well, yeah, because there's not even going to be a benefit in this case. So the risk totally outweighs the benefit. Cyclosporin A is great if T cells are your problem. But if T cells aren't your problem, then it's not going to be that useful. And the other thing to mention is it is a really broad way of reducing immune responses. And we're going to see this some in the next few slides. We're going to come back and see some similar types of issues when we actually talk about cancer next week. That one kind of general problem in a lot of biomedical sciences is that we've got some really cool treatments for things, but a lot of them are really broad. And so you'll see with cancer, like we talk about chemo or radiation, kills cancer cells, but it kills a bunch of other cells too. There's this problem of breadth. And what we really want to do in all of these cases is kind of try to narrow down and not harm or kill everything, but maybe try to target things that are more specific, right? So, at any point in this semester, have you heard me focus on the word specific before? So where have you heard, where did we think about specific? Yeah.
Antibody specificity.
Antibody specificity. I mean, we really talk about it with adaptive immune responses, but particularly with antibodies. And so one place where immunologists have made a big impact is that we've realized we can take advantage of the fact that antibodies are specific and try to make therapies less broad. And some of this is a cancer, comes up a lot in cancer therapies, and so again, we're going to talk about that with cancer immunology next week. But this has also really revolutionized the way that we treat autoimmunity, because we've started to use antibodies that can be more specific against whatever our problem is. These are known as sort of using biologics. And so if you've ever heard about things like using biologics when hearing about drug discovery, usually they mean like a protein. Usually they mean an antibody. And we can use a number of different types of biological therapies. I'm going to come back to this slide in just a second because I want to mention this one really quickly. This is actually pretty out of date at this point, but this was telling you about different kinds of things that pharma companies were selling in different years. And the numbers on here are billions. So note that like making small molecules, like doing fancy chemistry, yeah, that is definitely the majority. But if you look at change over time, the thing that's really changing over time and is sort of starting to take over the pharmaceutical industry is the use of monoclonal antibodies for therapies, be they for autoimmune disease, be they for cancers, be they for many, many other things. And so while I'm going to tell you about antibody therapy for autoimmune disease a little tiny bit, and I'll have to come back to the rest of it at some point in time because I have 1 minute left. Know that even if you're like, yeah, I'm never doing immunology again, understanding enough about antibodies to understand monoclonal antibody therapy is going to become really important in the future. And the one last thing I want to mention that's sort of shown here is that you might imagine a problem with doing monoclonal antibody therapy. So to give you an example, my dad takes one of these monoclonal antibodies that I'm going to tell you about at some point. He injects it into himself. I think right now he's monthly. He's been on, I first heard about one of these in a class in grad school in 2002, 2003, and convinced him to get on it, and he's been on one of them basically since then. And so the frequency of injection has changed, but I'll say monthly right now. You hear that? Basically, you can also imagine it almost sounds like we're doing passive antibody therapy, right? He's injecting antibodies into himself. And we just talked about a way that could be a problem, right? And so one of the things that's also been really helpful with all of this is that we've figured out ways to actually make antibodies in the lab that are less foreign than the originals were. So originally, we were using antibodies that we got from mice. We then figured out ways to engineer so that only the variable regions were from mice, the rest were from humans. Then we figured out a way to engineer so that only the CDRs were from humans, or from mice, and the rest were from humans. Then we figured out a way to engineer and actually have mice make fully human antibodies, so they're not foreign and can be transplanted again. And so this has been another big benefit of our ability to do antibody therapy. If you ever see the name of a drug, and the name of that drug ends in MAB, MAB, that means it's a monoclonal antibody. Anything you ever hear about, that's something MAB, monoclonal antibody. Whether it is, if it ends in OMAB, then it's mouse. If it ends in ZMAB, then it's just mouse variable region. If it ends in ZUMAB, then it's just CDRs. If it ends in UMAB, it's all humanized. And so you will like this assignment. Go watch TV, see the ads for different types of drugs, and see how many times you hear about OMABs and UMABs and all of these whatever MABs, because you will be shocked at how frequently you are hearing and seeing about these things. And every time you see one, you'll be like, that's an antibody, that's an antibody, that's an antibody with those drugs. We'll talk more about how some of these drugs work sometime. I'll figure out when. I'll see you guys on Friday.